Hi, everyone. Thanks for joining us today. I'm filling in since Sophia is taking a very well-deserved rest day. Um, so hopefully we have a couple more people showing up in the next few minutes, but we'll go ahead and get started. So Felix Reichling is going to present today. He is a senior economist at PWBM. He does most of our health modeling. And before joining us, he was at CBO, where he was the chief of the fiscal policy analysis unit in the macroeconomics division. So I'll turn it over to you, Felix.
Thanks, Cody. Thanks for the nice introduction. So we are here to talk about healthcare, which is very timely and important. So we're going to talk about how we model healthcare and some of our analyses that we've done so far. So let's get started. The outline of the talk, I'm going to spend a few minutes talking about challenges for healthcare policy. Just a quick review of the types of models to think about, and then I'm going to give you guys a quick overview of our healthcare model, and then we're going to talk about the Biden analysis that we did just a few weeks or months ago now. And then if we have time, we're also going to talk about our analysis for Medicare for All. So what are the challenges in healthcare policy? And of course, those affect the economy in big ways, since now healthcare in the US is roughly 20% of GDP. The big challenges are, of course, costs are really high in the US, much higher than in other countries, and I'll show you some data on that. But not only is cost high, but cost growth itself is high too. And as a result, people don't get health insurance, and some people also don't get medical care that is needed. And all of that has implications for the health of the population and for economic outcomes. And our model will capture all of these effects in one integrated framework. All right, so the next picture, just to give you a quick background, I'm sure many of you guys are already familiar with this, but the federal government spends a lot of money on healthcare. I'm sure you're all aware that Medicare and Medicaid are the two biggest programs with a combined of almost roughly 5% of GDP. So this is data from CBO, by the way, for 2020, fiscal year 2020, that is. But another big item is private health insurance. The federal government subsidizes private health insurance premiums with almost 1.5% of GDP. And that is a big amount of money that, when you think about, for example, Medicare for All, is highly relevant. For example, when you think about how to pay for it. All right, so this is a comparison of OECD countries. I picked the top 10 spenders in the data set of 37 countries here. What is interesting here is that the United States spends more than any other country, and I think we are all well aware of that. What we are less well aware of, I think, in general, is that we get fewer things for the amount of money we spend, like doctors and hospital beds, but also worth quality, like life expectancy and preventable death. For example, while the spending in the United States as a share of GDP in 2019 was roughly 55% higher than the average for the next 9 highest spending countries, life expectancy was 3.5 years lower. Preventable deaths were 60% higher. We had roughly 30% fewer doctors than other countries, and 50% fewer hospital beds. So it seems like in any kind of other industry, if we would pay a lot more for getting a lot less and a lot worse, would be a huge problem. And it is in the US too, except that there has been relatively little to address these changes. I mean, the ACA was one big step, but there's a lot of work that can be done to improve the situation. All right, so this figure shows you the amount of excess cost growth in healthcare. So excess cost growth is the amount of healthcare growth that is above per capita GDP growth. And this is these are projections that CBO made in their long-term budget outlook, and it shows you the excess cost growth rate for private health insurance in blue, and then Medicare in purple, and Medicaid in gray. And what's important here is that private health insurance in the US sees a lot higher excess cost growth than, for example, Medicare. Private health insurance has a problem with reining in costs. And this is, for example, one reason why people call for Medicare for all, because those people often argue that you can provide more cost-effective healthcare through the federal government than through private health insurance companies. All right. So what does this mean for people's health and their healthcare options? So right now we have roughly 10% of the population is uninsured. And by the way, going back to this graph, I should mention that not only does the US spend roughly 55% more than all these other countries, but all these other countries provide health insurance to the whole population, not just 90% of it. So there's, in addition to these factors here, the US also fails to fully insure their entire population. And so here, under current law, well, right now we have roughly 10% of the population is uninsured, and our model predicts that that number will only increase in the future while healthcare is getting a bigger and bigger share of the total economy. And the reason why it's getting a bigger share is because the excess cost growth. It just grows at a faster rate than the economy itself. And so by 2040, for example, our model would predict that the fraction of the population without health insurance went from 10% today to 20% if nothing happens. Of course, without health insurance, people's options to pay for medical treatment are also limited. So what also happens is that the fraction that forgoes medical treatment will increase in the future. So today in 2020, the roughly 4.8% of the population, of the entire population, did not receive medical treatment, necessary treatment, because of its high cost. Among 18 to 64-year-old ones, that was actually 6.5%. And if you even look more granular, the 45 to 64%, the 64-year-olds had a 7.5% 0.5% chance of not receiving healthcare as necessary. Among the uninsured, that fraction is a lot higher, about 19.2%. But even among those who are insured, 3.5% did not receive necessary treatment. And that might be the result of high co-payments, for example, high co-insurance amounts in some insurance plans. And of course, you see all the other gradients too. For example, if you're higher income, you're more likely to get medical care than if you're low income. If you have higher education, you're more likely to get medical treatment than if you're low income. Low education. There are also racial inequalities here. So this is a generally speaking a problem. And what happens when you don't get necessary medical treatment is that you become less healthy over time. Okay, so let's talk about the types of models. And this is a review, so I think you guys mostly have learned about this already. So there are different types of model: short-term versus long-term. Kind of what time frame are you looking at? Structural versus reduced form. Basically, the question is, do we use economic theory to write a model, or are we just looking at kind of statistical relationships? Is it micro-founded? Do we look at the household level, the individuals, or are we just looking at macroeconomic aggregates like GDP or investment? These are all important choices. In particular, the structural versus reduced form, I want to stress that is very important. I mean, they're all important, but think about somebody who, the problem with the reduced form, unless you have had a policy reform or proposal that looked just like the one you're trying to implement, and you have data for how that worked, you have very few means to actually forecast what that policy proposal would do to the economy or to households. Think of somebody who is doing weather forecasting in the desert, and he collected 10 years worth of desert data, and now there's a rainstorm coming that he does not have in his data set, and he's supposed to project how much rainfall is going to come down. If you would use the statistical relationship, that would give him absolutely, or her, no indication of how much rainfall there would come. So you would have to use a structural model. And so that's what we are doing here. First, we're using a long-term model. We're looking at a model that doesn't just analyze these policies over the 10-year budget window, which are important, but many policies like healthcare, infrastructure, education pay off well beyond the 10-year window. So we want to know how their long-term effects shape the economy, and in the case of healthcare, the population as well. However, it's important to note that doesn't mean that we just look at a steady state 20, 30, 40 years out. We actually capture the entire transition path from today's policy change to how the economy looks at some point in the future. And importantly, our model is a structural model. It is built on economic theory. And then we use statistical relationship and real-world data to calibrate the model. The calibration of the model basically means that we have to give the model parameters so that the model results look similar to what it does in the real world. So we want to have a model that is based on theory, but that kind of generates an economy and household behavior that is consistent with what we see in the real world. And for that, we need to look at statistical relationships. Also important, our model is micro-founded. That means we model each household individually, and we have lots of different households in the model. And we are trying very hard to get each household's decision to be very similar to what it is in the real world. So if somebody in our household is 35 years old and makes $50,000, we want him to, that person, to face incentives and decisions that that kind of person would face in the real world. Otherwise, the model would be slightly off and produce results that wouldn't make a whole lot of sense in the worst case scenario. Of course, the Lucas critique, aggregate relationships can change based on people's expectations about policy. Our model takes care of that as well. All right, so let's dive into what our model is, what it does, and then move on to the policy analyses. So our model is an overlapping generations model, which basically means that we model households over the entire life cycle. People enter the economy at age 21 and can live up to year 100. They retire at age 65 with certainty in our model. That's kind of to make it a little more tractable. But they face uncertainty about their future wages, their future health and medical costs, and their mortality. And the way it's set up in the model is that if you are in worse health, then you're going to face higher medical costs, but also a higher mortality. So they all go together, and just like in the real world, we estimate all these from the real world data. And households in the model can choose how much to consume and save, how much to work. They can choose their health insurance and whether to be insured. And they decide whether to receive medical treatment or not. We do assume that all retirees sign up for Medicare. And so there's no real insurance choice there. And important for healthcare policy, our model captures several neat things. For example, their life cycle effects. Older households are more prone to health risks, and health expenditures are much higher for old people than for young people. Their intergenerational effects, like young workers, they fund Medicare for retirees, and older workers affect younger workers' health insurance premiums, because older workers typically have a lot higher healthcare spending than younger workers. Health also in the model affects workers' productivity. So if you're healthy, you're more productive. If you're sick, you won't be able to work as much, and you won't be as productive anymore. But health also affects future health. So whether you're healthy today has an effect of how healthy you will be tomorrow. So if you're very healthy today, your chance of ending up healthy tomorrow are a lot higher than if you're in poor health today. So this is our estimate from PSID data, the panel survey of income dynamics, of earnings ability by age and health state. So here, H1 refers to health state 1, which is the best health, and health state 5 is the worst health. And these are actually health states that are in all these surveys. They're included. They are subjective health states where people are being asked how healthy are you? What's your health like? And health state 1 is excellent, and then very good, good, fair, and health state 5 is poor. And you can see that there are big difference. Actually, somebody in health state 5 makes roughly 50% of the average wage of somebody in health state 1. And so this is something that we incorporate in our model, and that also affects the trade-off for people that decide not to get health insurance, for example, or not to get medical treatment. So in our model, there are different types of insurances that we model. Households with earnings above the threshold can buy employer-provided health insurance. Roughly 56% of the population in 2019 were covered by employer-provided health insurance. Like in the real world, we calculate premiums based on all the pooled expenditures plus some administrative costs. And the employer-provided health insurance is subsidized by the firm. I think they pay roughly 75% in the data, and the employee pays 70. Well, the employee pays 25, the employer pays 25, and is fully tax deductible. Retirees enroll in Medicare, including parts B and D, and this assumption is really not that far off, because roughly 92% of all Medicare recipients enroll in parts B and D. Medicare Part A is funded by current law payroll taxes on workers, and the Medicare shortfall is deficit financed. Basically comes out of the general budget right now. Those with low income and assets or large health expenditures can get Medicaid, like in the real world. So some important features here in our model: workers can choose not to buy health insurance. So what's the benefit of that? Well, they don't have to pay the health insurance premiums. So if they are very certain to not get sick next period, it might be in the, optimally for them to not commit today to purchase health insurance for next year. But the downside is, of course, that if they need medical care next period, they have to pay everything out of pocket. So if they do forego employer-provided health insurance, they give up the employer subsidy. Like it is true today that if you choose not to enroll in your employer's healthcare plan, they don't just pay you as cash wage the the employer subsidy. You forgo that amount, and they also lose any tax benefits. So if they would, for example, go buy insurance in the private market, they would not get the tax benefits at all. But households can choose not to buy medical treatment. So what are the trade-offs here? Well, one is you don't pay out-of-pocket expenses, and those can be, depending on your age and health state, those can be quite high. But if you don't do that, if you don't get needed medical treatment, your probability of moving into a worse state next year increases. So you basically gamble with your health if you don't get needed medical treatment. And this is actually a surprisingly rare feature in health models. I've not seen this before, but it is very there's a lot of data, if you know where to look, on this issue that a lot of people go without needed medical treatment. All right, so let's talk about the Biden healthcare plan. The Biden healthcare plan focuses on two things: access and affordability. It tries to increase access to healthcare by first lowering the Medicare eligibility age to 60 from currently 65. It's trying to expand the ACA insurance marketplace by getting rid of the maximal income threshold for which you eligibility threshold for the premium benefits and the premium tax credits, and it makes the premium tax credits more generous. It also expands long-term care for the retirees. It increases affordability by allowing Medicare to negotiate drug prices and for consumers to import drugs from abroad. And then there's some other policies to decrease drug prices that have a much smaller effect, such as limiting launch prices for new specialty drugs and limiting drug price increases to inflation. Biden also announced a plan for a Medicare-like public option, but he hasn't really provided any details that would help us model such a policy. And you can think that depending on how you set up such a policy, the government could end up anywhere between not paying anything to paying all of healthcare expenditures. And the reason is simply that you need to compete with private insurance plans. So as soon as you offer a plan that is, after all of these employer subsidies, looks better than the private plan, a lot of people who are currently enrolled in private plans would switch to the public option, which would have a cascading effect for private plans. They would get probably more and more expensive, and eventually the public option would be the primary plan, health insurance plan. On the other side, if you would have a public option that would be priced in a way that it would be more expensive than the employer-provided health plans, you would see very little to no signups there. So it is very tricky with the way that private health plans are priced right now to the consumer, with the employer subsidies and the tax benefits, to come up with a public option that can compete in a way that would allow some, but not all of them, to join. So if the public option did look exactly like current law Medicare, we analyzed this, and you can go to this website and look at the outcomes there. We have a stylized deficit-financed universal Medicare plan that we looked at. But yeah, the public option sounds like a an interesting idea, but I think the details will be will really matter, and something we'll might look into in the near future. So what are the effects of the Biden proposal on premiums and enrollment? Well, first of all, we assume that drug prices would go down by roughly 60%. And this is basically the difference between drug prices in the US and other industrialized countries like the UK, Canada, and Japan. And these are numbers that the Congressional Budget Office also used to analyze HR 3. That decrease in drug prices will directly lower premiums. So for example, then older people tend to have higher healthcare costs. So if you take the 60 to 64-year-olds out of the insurance pools by expanding Medicare, that will also decrease premiums for younger people. So one thing here to note about the drug pricing is that allowing Medicare to negotiate prices and consumers to import price from abroad has basically the same effect. It will decrease drug price, and here we assume that they will go down by 60% for everybody, Medicare or not. So of course, the younger population is a lot less dependable on prescription drugs, so their prices overall will decrease by slightly less. Whereas Medicare recipients use a lot more prescription drugs, and so they will be seeing more of the benefits. But overall, the private health insurance premiums for the 21 to 64-year-olds will go down by between 23 and 28%. Not surprisingly, those premiums will go really down for the 60 to 64-year-old group because now they pay much lower Medicare premiums. But still, for those who are between 21 and 60, health insurance premiums will go down by roughly 12%. That's not small. The one key assumption here, though, and we have to highlight this, is that we assume competitive labor markets. So if healthcare costs go down, employers will eventually pass those cost savings on to their workers in the form of lower premiums. Because if not, then workers would move from those firms to a company that offers higher pay and lower premiums. Because wages are taxable compensation, that would also mean that government tax revenue is going to increase. Because we're basically shifting money from tax-preferred compensation, the insurance premiums, to taxable compensation. Okay. So now that people are better insured, although that insurance premiums decrease, we would expect that also has an effect of the number of people with health insurance. So what this actually shows you is the population without health insurance. That's the flip side of that. So under the Biden plan, the total number of in total, the number of people without health insurance would decrease from 10% under current law to 6% in 2030, a decrease of 4 percentage points. And by 2050, that would increase by 6 points. And this comes, you can decompose this by those under 60 and those 60, between 60 and 64. So for the older, we would see no more uninsured for the 60 to 64 group, because everybody would enroll in Medicare, just like current beneficiaries do. And that would have a big decrease between 6 and 9 percentage points in future years. But even for the younger group, the uninsurance rate goes down by 4 percentage points for each of these years. So the Biden proposal doesn't completely get rid of the uninsured, but it does decrease current and future uninsurance rates by significant amounts. The health outcomes as a result will also be better. More people being uninsured means that fewer people will forego necessary medical treatment. And with more people getting medical treatment, the population overall is going to be healthier, and we even see an increase in the population size. So by 2030, under the Biden plan, only 4% of the population will forego medical treatment, rather than the 7% under current law. Because of that, among the population, the healthy will be roughly 0.1%. 0.1% of the population will be healthier, and the fraction of the sick people will be lower. Of course, this is a very slow process because it takes time for people to get healthier under the new insurance. So by 2050, we already see that the percent of the population that is healthy has increased by 0.3%, with an according decrease in the sick population. Because healthy people have a longer life expectancy, the overall population size also increased by up to 0.2% in 2050. All of these changes have effects on the American economy. And in particular, because people are now better insured overall, households don't worry so much about bad health shocks and the associated high medical expenses anymore, which makes them reduce their hours of work, and they don't have to self-insure to basically save in case they experience a really bad health outcome, and they also save less. But of course, with with less work and less savings, our models predict that GDP falls slightly in the beginning. Like after 10 years, GDP would be down by 1.1% compared to current law. But the public debt would be also slightly lower by 5%. And the reason is that you now have a bunch of people, the 60 to 64-year-olds, who pay a lot higher taxes, and the working age who also pay higher tax on the insurance premiums that previously were tax advantaged. So you overall have more tax revenues coming in than outlays go up. By 2050, GDP will be just slightly lower than what is on a current baseline. But it's important to highlight here that people are probably worried less about GDP and than their welfare. And their welfare depends on how much can they consume and how much do they have to work. And since hours worked is lower, it's likely that people will be happier in this new economy than under the baseline economy, even though GDP is going to be slightly lower. Okay. All right, Cody, do we have time to talk about Medicare for all, or?
Oh, sorry, I was muted. We can pause here for a second and see if there are any questions.
Yes.
Wait for... if there aren't any questions, then yeah, we can go ahead and talk about Medicare for all.
All right. So let's then talk about Medicare for all. So this is an analysis of Senate Bill 1129 that has similar goals and effects as the Biden plan, but is much bigger in the sense that it doesn't just expand Medicare for those 60 to 64, but to everybody in the economy. So it covers all medical services in 13 categories, including many not covered by current Medicare, expands Medicare to dental, vision, hearing, and home and community-based long-term care. Coverage is universal. It eliminates all other insurance options except for Medicaid's coverage of institutional long-term care, which is not covered by Medicare for all. And it puts in place cost controls to lower overhead and reduce reimbursement rates for providers. So Medicare pays on average 16% less than private insurance companies. So it basically will expand not just it will not just enroll more people into the Medicare plan, but it will also change the cost structure of the entire healthcare industry here by replacing private insurance through Medicare. And what's more, also it will affect Medicaid because all those who receive Medicaid currently would become eligible for Medicare. And Medicare is the primary payer. Medicaid would also only pick up the Medicare premiums or out-of-pocket spending that is not covered by for treatments that are not covered by Medicare. So the Senate bill did not specify how it would be funded. So we looked at three options here. We looked at deficit financing, increasing payroll taxes, and raising premiums to pay for Medicare for all. We also looked at a range of different assumptions. For example, will provider reimbursement only drop by 60%? We also have an option where it only drops by 8%. How much will home care-based long-term care consumption increase? We have different assumptions about that. And how will how high will overhead costs be? And there's a big debate of what these different overhead costs are and why they are what they are and how much they can change. So we did analysis of different options here. So the various scenarios that we analyzed counted for over 100. And you can find all of these scenarios on our website if you're really interested. So the health outcomes across all of these scenarios are basically the same. Longevity increases, and this is measured in years. So by 2060, people born then have roughly 1.8 years higher life expectancy than under current law, which would also increase the population size by roughly 3% by 2060. And the percent of the population that are in bad health would decrease by between 0.9 in 2030 to 1.2%. These are percentage points, not percents, percentage points compared to current law. And the percentage point, like the percent of the population foregoing care would decrease dramatically, basically going down to zero under these options. Or at least close to zero. There's still some out-of-pocket expenditures that people would have to pay for. So what are the budgetary effects of Medicare for All? You can see two tables here. One is deficit financing on the left side. On the right side, the funding mechanism is premium financing. So households are being charged an insurance premium that for poor people would be paid for by Medicaid. We assume that the initial drop in total health expenditures is 16%, so that basically providers would get 16% less, paid less than under current law, and that there's a huge increase in home and community-based services of 200%. And a total overhead cost of 3%. So to put that number into perspective right now, private health insurance has an overhead cost of roughly 15%, which is also the max allowed under the Affordable Care Act. Medicare and Medicaid have slightly lower overhead cost of 9% and 7%. The reason why Medicare has a relatively high overhead cost is because of Medicare Advantage. So pure Medicare has a overhead cost of between 2 and 3%. So what we are assuming here is basically that if we go to Medicare for All, the overhead cost will be close to that of current pure Medicare. And so what you see here is the effects of federal debt, income tax revenues, payroll tax revenues, and Social Security spending. And important here is if you look at federal debt, if you finance a Medicare expansion through deficits will grow a lot over the next decades. And federal debt would be roughly twice as much as it is today by 2060. Under the premium financing, however, you will find that federal debt actually decreases. And the reason is that if you have premium financing, you have that people will work more and save more overall, and that increases tax revenues compared to the deficit financing. And after a while, you see the macroeconomic effects kick in. With lower debt, then comes more capital. With higher capital comes higher wages, and higher wages means that people will work more than under the baseline. And so these are two polar opposites. The premium finance, the payroll financing is going to be somewhere in the middle, because payroll financing also increases tax revenues, but it's compared to the premium financing, it does discourage work by taxing work, and so the economic outcomes are not quite as beneficial as under the premium financing. Okay, is there another slide? Yes. The economy also would look better under premium financing than under deficit financing, and that is almost entirely due to the deficit results. Higher deficit typically in these models has a big effect on capital stock. It's called crowding out. And we see here with doubling debt between now and 2060, the capital stock would be a lot lower than it would be in under the current law baseline, and GDP would be roughly 24% lower. Under the premium financing, the capital stock is roughly unchanged, and GDP would be almost unchanged from current law policy. But output per hour worked would be a lot higher under the premium financing, meaning that people are more efficient than under the deficit financing. Also interesting here is consumption, to look at what happens under deficit financing. People get basically a windfall today, and they consume much of that. They decrease hours of work a lot and increase consumption, and basically live from the deficits. Under the premium financing, hours of work are decreased by less so because they have to pay for higher premiums, and consumption increases by less, and it stays higher than under the deficit financing. Under deficit financing by 2060, consumption is actually lower than under current law baseline, while it's 5%, 6% higher under the premium financing. And here you can already see what the welfare implications are. Under the premium financing, people work less and consume more. Those are really two of the main things that people care about, how much they work and how much they consume. And eating more and having to work less for that will mean that they will be better off in that scenario. All right, so as I mentioned before, if you want to see all the effects of all the different combinations of funding choice and assumptions, you can go to our website and see them all. All right. Any questions?
Felix, one from me. Could you talk a little bit about, welfare effects? You might have mentioned this earlier, but I just missed it. But
you mean in addition to what I just said?
Yeah.
Yes. So welfare effects. So typically, what people on Capitol Hill and the press and most people are focused on the headline GDP numbers. How is GDP changing due to certain policies? And GDP is a very crude measure of welfare. Basically, if we would cut Social Security now to zero, and everybody who is retired would find a job and work, would greatly increase GDP. But I think very few people would say that now retirees are better off, or that anybody's better off because of that. So welfare, the way we measure welfare is by looking at how people's consumption and leisure changes over the life, and how certain those consumption and leisure streams out over the life cycle. So, for example, if you have to work more to afford a certain amount of consumption, your welfare is probably going to go down because you're going to have less leisure time. If your consumption over the rest of your life is more uncertain, if there's more uncertainty because you don't have as good an insurance, for example, as good a health insurance, your welfare will be lower. So by providing a policy that will increase consumption and leisure and make your consumption over the rest of your life more certain because you have better health insurance now, overall will increase your welfare than what you had under the baseline. Does that help, Cody?
Yeah, that's great. Thanks.
Any other questions?
So we can stick around for a little bit if there are any more questions. You can just put them in the chat or in the Q&A box. But otherwise, thank you all for attending. And as always, if you have questions about the program, you can always email me or Sophia. So thank you very much.
Thank you, guys.